Okay, can you see my
Yes,
slides?
yes, I can.
Okay,
Okay,
lovely.
I think it's past 1 o'clock, so we can get a move on. I would like to welcome all of you who are joining in live from Zoom as well as on YouTube. This is the second of our webinar series, the Breast Cancer Insights, Breast Care Insights. And today we thought of discussing more of a surgical topic that comes into play in our day-to-day practice. If you're a trainee, if you're a surgeon, an experienced surgeon, or a novice surgeon, or somebody who's willing to know what happens in the realm of breast cancer surgery, this would be very useful. Or even a breast scanners, this would be useful to see how the decisions are being made. And we looked at how we're trying to look at how difficult tumor locations are handled, especially in the UK, where our speaker is from. Mrs. Kayani is somebody that I had the pleasure of working for close to a year. She has a vast experience in breast cancer surgery, initially in her home country as well as in the UK. She has worked as an oncoplastic a breast surgeon in a few trusts, and currently she is a consultant at the University Hospital Birmingham NHS Foundation Trust. She's also published plenty of articles on different areas of breast cancer surgery. And so, Mrs. Kayani, over to you.
Thank you very much.
I would just add up if you have any questions, pop them in the chat section or on the YouTube's chat. At the end of the discussion, we'll go through those questions as much as we can. Over to you.
Okay, thank you so much. Thanks for giving me the opportunity to speak to my colleagues today. I was so excited to talk about the topic. As I recall my previous days when I was a junior surgeon, this was a surgical challenge for a junior doctor or a junior surgeon to start off with some tumor where you scratch your head and don't know what exactly to do. And I also do remember the days when we used to make decisions of a mastectomy because of unacceptable scarring due to some certain tumor locations. So it's really useful to talk about those tumor. So let's make a start. That's where I work in Birmingham. A bit of layout of my talk today. I'm going to give you a brief background of basics of breast surgery, an overview of oncoplastic breast surgery, and then we are going to talk about difficult tumor or challenging tumor location and the techniques that are employed in current day practice. Um, as we know that breast conservation surgery has become a standard of care, and it's not just gives good outcome in terms of quick recovery, fewer complication, better cosmetic outcome, as patients they keep their breast with a better body image. The recent real world data has shown a survival benefit of breast conservation surgery over mastectomy, in fact. So this remains the treatment of choice for early breast cancer. Um, just taking a step back, I would like to just share with you what we are taught as basics of surgery, where the optimal incision placement should be. If you have a look, radial scars are favored for 3, 6, and 9 o'clock position. Then above areola, circumareolar, or periareolar incisions close to the areolar areas, and lateral radial incision for the lower quadrant, and a diagonal or a vertical radial incision for the upper outer quadrant. These are associated with better outcome, allowed minimal resection, and the breast tissue to fall in its place. So just um, following these principles, along with, I remember when I was trained, so I was taught to do a cylindrical excision of the tumor, which has meant like a block of tissue removed from skin to the pectoralis major. Is slightly changed. Now we know that the fusiform or a triangular excision gives a better result, especially for the 6 o'clock, 3 o'clock, and 9 o'clock. The transverse oriented ellipse does not give better results in the lower quadrant of the breast, especially for the 6 o'clock tumor. So a vertical is better than upper outer quadrant, laziest or diagonally shaped elliptical or triangular excision gives a better result as the surrounding breast tissue falls in its place. Another good practice to do is to once you've finished your wide local excision, mobilize the breast parenchyma of the pectoralis major, which allows the approximation of the pillars of the breast of the defect. So, with just following those principles is perfectly fine to achieve good cosmetic result without using any complex techniques. But sometimes we end up in these scenarios. If you look at these pictures, I'm sure the surgeons have followed these principles, but still ended up in having a deformity, which is quite unsightly and not acceptable in current day and age. Um, so that has resulted in the lower quadrant, loss of volume, nipple areola complex, deviated downwards, and a scar contraction here, and the scar contraction with the volume loss and nipple deviation upwards. So we know that what happens after surgery with the removal of the parenchyma, scar necrosis, a collapse and contraction of the cavity, removal of skin, and trauma due to fat necrosis, blood supply, poor scar placement. They all tend to contribute to deformity of the breast. So what are the predictors for the outcome of the breast conservation surgery? We've learned over the time breast size is important. So not all patients, they come with the same size. Small breast obviously will have less volume and more risk of scarring, but large breast equally present a challenge of extensive mobilization of tissue leading to fat necrosis, more tissue trauma, scar contractions, wound problems. So large tumor is also a risk factor for increased scarring when but the tumor size is larger than the breast, it leads to more extensive resections, as a result, more scarring. So tumor location is an important factor. So even with the areas in the superior, medial, and inferior part of the breast, a small resection could lead up to a lot of scarring and deformity. Laterally placed scars or tumor resections, they are slightly more forgiving, and you could comfortably remove 10 to 20% of the breast tissue without causing much scarring. Then having to go back in the breast for the re-excision of margin after lumpectomy also results in scarring, seroma formation. Obviously, radiotherapy and especially radiotherapy boost leads to the scarring of the tissue. So we have known over the time that as the more volume is removed, it's directly proportional to the unsatisfaction what the patient had. As it comes up to more than 20% of the volume from highly satisfied, it changes to equally satisfied and unsatisfied patient. But as the volume of resection increases, you will end up having unhappy patients. So Krishna Klaff et al. Gave us two classifications based on excised tumor volume and cancer location, which helps us to identify what surgical technique can be employed. So there were three main elements of consisting of excision volume, tumor location, and glandular density. So glandular density, which is something you will determine on imaging, or especially mammogram of the breast. He proposed level one excision or techniques to be employed if less than 20% of the breast volume is expected to be excised, which will be a combination of technique using local glandular reshaping. But if it amounts to more than 20% of volume of excision from the breast along with tumor, then you would need some complex surgical techniques for tissue replacement, such as reduction mammoplasty or a flap replacements. So level one, what is level one oncoplastic? Is mainly a combination of mobilization of the skin flaps, excision of the tumor, then mobilization of the glandular tissue of the pectoralis major, mobilization of nipper complex, and then reapproximation of glandular tissue. Level two oncoplasties, they allow you to go up to the 50% um, in the larger size breast. Involves a combination of excision of skin, repositioning of nipper complex, tightening of the skin envelope, preservation of neurovascular supply. So, and those techniques are based on patient selection and patient factors such as volume, available ptosis of the breast, patients' aspirations or their preferences, and also the surgical experience of the um, breast surgeon. So this is, I think, the most widely used diagram from Nottingham Group, which they are trying to explain the it shows actually the breast volume and size of the breast to be and percentage of the breast tissue to be removed with four commonly used breast conservation techniques. So for a smaller volume, they will be up to 5%, to 5 to 10% excision allows you to have simple volume excision, and more than that would require consideration for volume replacement. Subsequently, you can see the more the volume, you can extend the scope of your techniques. Before we go on to talk about the techniques, obviously our first primary goal is not to do any harm to the patient, as we are taught in our oath. So it's important to understand and make a decision whether what you decide or you recommend is the patient appropriate, your patient has got appropriate factors, which would you need to look at patient factors such as diabetes mellitus. We know with the uncontrolled diabetes, more risk of wound-related complications, and long-term diabetics, they do have small vascular disease leading to microvascular angiopathy, smoking, alcohol, other addictions. And you have to pay attention to the previous wound healing problems such as keloid, previous history of breast scars and scar placement in the breast. And has your patient recently received any new adjuvant chemotherapy, or they have any history of malnutrition? Okay, so let's go to refresh ourselves with the quadrant of the breast, which are important for what we are going to talk about. So we all know this diagram. We are aware of four quadrants of the breast. So if you move on to the lower portion of the diagram, it shows what do you commonly come across with the sites of the tumor. As we all know, upper outer quadrant has got the majority of the cancer, up to three-fourths of the cancer in upper outer quadrant, then upper inner you will see up to I think it's up to 20%. Then lower inner quadrant and central, they are less frequent tumors. So in majority of your practice, you will be seeing lateral, but there will be a considerable portion which will be presenting with the tumors, what we call the challenging or difficult to treat locations. So, what are those that would pose a challenge for your surgical expertise? They are central tumor or retroareolar region tumor. This is considered one of the most challenging lesion because the excision requires removal of the nipple areola complex and the considerable techniques for the restoration of the central part of the breast. Upper inner quadrant, they are this well, aesthetically they are sensitive area close to the cleavage. No, just a thin coverage of the tissue and no availability of surrounding breast tissue to mobilize. So again, it's a considerable challenge for the treatment of upper inner quadrant. Lower pole tumor also pose a considerable challenge as larger resection leads to the bottoming out of the breast and nipple displacement. And as we all know, a famous bird beak deformity in the breast. Upper outer, they are less challenging, but you will come across with some challenging cases. So lateral quadrant tumors are more forgiving. Okay, central breast tumor, they are about 5 to 20% of all the cancers. They were thought to be associated with the larger tumor size, high TNM, and worse prognosis in a previously, known research. Um, we use a classification of the distance of a tumor from the nipple areola complex, and I think in all across the world, 2 centimeter is taken as a um, safe distance where you could avoid sacrificing nipple areola complex, but anything within 2 centimeter of the nipple areola complex have a higher chance of involvement of the nipple, hence a central wide local excision or with arm block removal of the nipple areola complex is advised. This is a very simple diagrammatic representation of what I normally teach my registrars for a small breast size and a small tumor around the nipple areola complex, a simple ellipse, horizontal ellipse of the tissue would be sufficient. The important consideration here is the tumor are superficial, so one does not need to go all the way down to the pectoralis fascia, but you need to make that note in your operative recording that the deep margin is not up to the pectoralis major, so there's a scope to go back if there is cancer at the deep margin. So it leaves a transverse scar which usually leads to a flattening of the central part of the breast. And similarly, a small elliptical oriented incision can also be used without causing much deformity to the breast. For medium-sized breast, simple wide local, sometimes you do have a satellite lesion on either side along with the nipple areola complex. So you can consider a melon slice with removal, en bloc removal of the nipple areola complex. And similarly, the melon slice can be converted into a vertical ellipse of the tissue for a medium-sized breast where patient factors does not allow you to use complex surgical techniques. That for the large size breast, um, therapeutic mammoplasty with nipple sacrifice or a retained skin island on inferior pedicle can be used. Um, these are a few cases where an elderly lady had a nipple areola complex tumor, not very, it was about, I think, 15% resection. So an ellipse was used to remove the tumor en bloc. And in this picture, there were two tumors in the breast. One was close to the areola, the other was in the upper central part of the breast. And this lady had a good sized breast, but she had multiple comorbidities, including being on blood thinners. So a transverse ellipse was used to remove the tumor with the nipple areola complex and the localized upper central breast tumor. So moving on to slightly complex techniques, Grissotti flap is one of the most effective technique which is used for small to medium sized breast. The breast needs to have a bit of ptosis for this technique to be used. So it's based on inferior tissue mobilized over a skin island. So en bloc removal of the nipple areola complex, then refashion this tongue of the tissue, mobilized from the rest of the lateral parenchymal pillars, dissection up to the pectoralis fascia, but in the base is kept intact. The blood supply comes from posterior and inferior part. It is mobilized into the defect, which is quite an effective technique for the medium or moderate size breast. For a small size breast, when you have to remove the nipple areola complex, unfortunately, there would not be enough volume available to mobilize the surrounding tissue. Hence, you would have to think about mobilizing the tissue from the inferior part of the breast. You can fashion an island of the skin on the mobilized tissue, and we're going to talk a bit more about it in the details. This could be based on the local perforator flap, such as anterior intercostal. Um, so sometimes you will have you would come across a tumor and just above the areolar margin, not exactly in the upper quadrant or not classed as a central one. So they also pose a bit of challenge. Any excision in that part just above the nipple will lead to considerable scarring and deviation of the nipple areola complex upward due to contraction of the scar. So, crescent mastopexy or bat wing technique, which is useful for these. So, the principles of an excision is two crescentic incisions are made above and below the tumor. The lower edge of this excision is at the upper margin of the areola. And laterally is extended to address in a triangular fashion to address the redundant skin. Your nipple will end up at the upper margin of the incision. So this will counteract any scarring and slightly upward placement of the nipple areola where you started. So this is used for the smaller tumors just above the areolar margin. Then I've come across this hemi bat wing, which can be used for the tumor just above the areolar margin, but more in the lateral part where you don't have to extend the lesion in the medial half or medial wing of the bat wing. So just a lateral wing is used to counteract any redundancy in the lateral part. Again, two crescentic incisions or circles, and then lateral wing. Vertical mammoplasty is something, a versatile technique which can be used tumors above the areola or below the areola, both equally. Um, effective. Um, So for the tumor around the periareolar area, up, a bit away from the, our mark cut off for the classification, over 2 centimeter away, but not in the periphery of the breast. Again, they also pose a challenge. And Benelli or donut mastopexy is a very useful technique where you use two crescentic circles around the nipple. The skin intervening is de-epithelialized, and the upper part of the incision is used to mobilize the flap, reach the tumor area, elliptical excision of the tumor, and then mobilization of the tumor pillars to close the defect. And then these are approximated. With, you might end up with some redundancy around the scar, but this settles quite well over the time. So it's quite versatile. It can be used for tumors in multiple locations around the periareolar area. Uh, so for a size of the tumor, which is in the periareolar area, but demands or more than 20% excision of the volume, then volume replacement techniques you provide a good alternative to restore the breast shape. So this is one of the patients who had, you can see the visible lump in the just above the areola at the margin of upper, inner, and central part of the breast, where it, resulted in a considerable loss of the volume and a flap, it's a MICAP flap, which was harvested in the lower part of the breast and mobilized into the medial quadrant of the breast. And this is quite extensive slide. It gives you, I think, all the possible um, procedures that can be employed. I think the choice depends on the availability of expertise and also patient factors. So if we move on to the next one, which is our next challenging location, is the medial tumors. So in the medial part of the breast, they account for about 1/5 of all the tumors. It used to be considered as a no man's land, associated with a high risk of cosmetic outcome because of the nipple areola displacement, shrinkage, and a visible defect in the cleavage. They make up to about 24% of all the tumor. Um, this is an interesting study which was done by Cochrane, and it compared the women's satisfaction with excision of volume for the medial and the lateral tumor. And you can see the level of satisfaction, which was much less as the tumor excision volume exceeded as compared to the laterally excised tumor. It is a major diagnostic dilemma and the treatment dilemma, how to treat the medial quadrant tumor. So some of the studies suggested that the volume replacement can produce superior aesthetic outcomes. And then volume replacement for the when the resection volume to breast volume ratio is high, basically large breast with the volume replacement technique gives better cosmetic outcome. So this is quite useful algorithm which was published in the study by Kang et al. For the small to medium size breast with the small defect, less than 10 to 15% of resection, could use the techniques tennis racket technique, which is a lateral mammoplasty, and a round block donut mastopexy technique. For the moderate defects, volume replacement is the preferred choice, which means either using a rotational flap or a perforator flap from the local area, or TDAP flaps. For anything amounting to 25 to 30% of resection of the volume, along with the tumor, it needs a larger flap with a greater mobility to reach up to the medial quadrant, and you'll have to consider an LD flap, or with experience, a TDAP flap can also be used, but these are complex surgical techniques. Medial quadrant tumor in a large breast can be easily treated with, I think it's a good option for the treatment is the therapeutic mammoplasty, which is reducing the volume and taking the tumor as well without leaving any defect in the medial quadrant. Then again, as I said, this technique is quite useful. It's used in lots of options around the areolar margin, which employs the two crescentic uh, excision of the skin around the areola and extension of the excision towards the tumor side. And just by rotating any direction, you could use for excision of the tumor around all the areas that are around the nipple. This would be only useful for medial tumor closer to the nipple areola complex. This was one of the case we dealt in our department with the excision of medial to lower breast tumor, resulting in a severe volume loss, contraction. So there were quite a few things to consider here: loss of skin, loss of volume, nipple areola displacement, and they were addressed with excision of the scar, release of the all the fibrosis, and replacement of the volume through a local perforator flap. As I was looking through the different options, and we know that they are difficult to treat. Sometimes you may not find any on breast conservation technique for the medial quadrant. So this was a study published by Nottingham Group, Steve McCulley et al., to use a free flap, tug flap, for the volume replacement after mastectomy. So these will be suitable for patients which have very small breast, and any BCS will result in extensive deformity in the cleavage, and if they are willing to consider mastectomy and reconstruction, that could be something can be used. These flaps are harvested from inner thighs, so they won't lose their backup for reconstruction, such as DF flap or LD flaps. Lower pole deformity is again quite challenging. Any tumors in the lower breast, if the surgically not excised appropriately, they leave weak deformity as a result of scar contraction, nipple areola displacement. Lower pole tumor can be excised based on the principle of triangular excision of the breast and mobilization of the surrounding breast parenchyma to fill up that defect. These can be, they are not difficult surgeries, and I think it requires only some experience in training. They can easily be mastered. Which the principle involves a triangular excision of the tumor along with the skin, and then mobilization of the lateral flap to close the defect. Again, this can be used for slightly laterally placed lower quadrant tumor. For the when you have some ptosis available and volume available, again, therapeutic mammoplasty gives a better outcome. This is a large patient with a large tumor in the lower quadrant that was up to, I think, 8 centimeter area with a microcalcification. This was excised with the 2 wires and therapeutic mammoplasty. Level 2 techniques were used to restore the symmetry of the breast. The lateral breast tumors. Lateral breast tumors, as I said, they are a bit more forgiving. And so this is lateral mammoplasty, similar to the concept of racket mammoplasty, where you excise the tumor from the lateral in an elliptical fashion, and then skin incisions are extended around the areola to counteract the scarring that develops as a result of the tumor contraction or radiation induced contraction in the lateral department, in the lateral quadrant of the breast. So, excision and repositioning of the NAC, and then mobilization of the parenchyma of the breast to approximate the pillars of the lesion. A bit of diagrammatic representation, what you extend the drawing around the tumor and the areola, surgical or oncological excision of the tumor from skin flaps down to pectoralis major. You can perform the sentinel node biopsy through the same incision. You don't need to have another excision in the areola, and then approximation and closure. So the lower tumor, which are at the border of the lateral and the lower quadrant of the breast, uh, is similar to principle of lateral mammoplasty, but this is called J mammoplasty. So this allows you to remove the tumor, readjust, and then mobilize both the pillars of the breast tissue to come together. It looks like a reverse J for the lower lateral quadrant tumor, and the similar technique for the medial quadrant is based on the V mammoplasty, which is again a pyramidal shape excision of the tumor, apex towards the nipple, base towards the inframammary fold, and then mobilizing the pillars of the breast to close the defect. But you will have to consider to reposition the nipple areola complex by de-epithelializing the superior part of the breast to counteract for the scarring. Um, this is a picture, again, a diagrammatic representation of what's called an S mammoplasty, which could be used for the tumor around the areola, lower border of the areola. So repositioning of the nipple areola, excision of the tumor to down to the chest wall, and it leaves a scar, something like that. For the small or moderate size breast, where you come across with a larger tumor excision, well, it needs to be replaced with the volume. Then the lateral tumor has a availability, or what we can use the lateral body fat to mobilize into the breast tissue based on the perforator flaps in the lateral part of the breast, which is nearly available in each and intercostal space. So there are a variety of those flaps available to restore the volume and lateral part of the breast, ranging from LICAP to T, L-TAP and T-TAP flaps. For a small breast size with a larger tumor in the lateral part of the breast where you do not have enough fat in the lateral part of the breast or enough volume to replace, then the inferiorly based dermoglandular flap can be utilized, and these will be useful for some patients with the comorbidities such as diabetes or other factors where you wouldn't want to use the vessel based, and these are based on the cutaneous fat. It's mobilized, deepithelialized to fill in the defect in the breast, and then the skin in the abdominal or the lateral chest wall is mobilized to close the defect. I think therapeutic mammoplasty is gold standard technique and answer to lots of tumor for large size breast where ptosis and volume is available. If you look at this diagram, it divides the breast into the zone of the tumor, and almost any zone or any location of the tumor with the appropriate size of the breast, that is the large ptotic breast, you could use this technique to remove the tumor from any quadrant of the breast. There's a great range of versatility of pedicles available for the therapeutic mammoplasty. For tumor in upper part of the breast, inferiorly based inferior pedicle mammoplasty, medial pedicle based mammoplasty for tumor in any of these locations or outside these locations. So you can use vertically bipedaled central pedicle, supromedial pedicle, and these pedicle of nipple areola complex can also be combined with a secondary pedicle to fill in the defects. So to sum up, this diagram gives you a good overview of tumor location and strategies available for considering the excision of the tumor. So excision of the tumor, medial and lateral, principle is same. Excision of the tumor and then repositioning of the nipple areola complex. You just reverse the direction and you can use the same technique for the lateral and medial quadrant. Above the nipple, omega or batwing mammoplasty, periareolar, Benelli or round block mammoplasty, tumor in the inferior quadrant or lower lateral part, J mammoplasties, L mammoplasties, V mammoplasty for the medial quadrant tumor, or inverted T mammoplasty, medial mammoplasties for 3 o'clock tumor. So, no, historically, I have lived in, and I remember the MDT discussions where 4 to 5 centimeter tumor was taken as a contraindication for the breast conservation surgery. It is no more. So, with the use of majority, so many techniques available, we have extended the uh, borders of breast conservation surgeries, and these have been employed in many clinical situations. So, and 4 to 5 centimeter is not a contraindication for BCS anymore. We have plenty of options available to restore the breast by using local rotational flaps, volume replacement, volume displacement, lipomodeling, downstage the tumor, uh, using neoadjuvant chemotherapy or neoadjuvant endocrine treatment. Multifocal tumor, again, is no more a contraindication where both the tumor or multiple tumor can be safely removed en bloc. Oncoplastic breast techniques can be employed. Those lesions may need bracketing wires or localization techniques. In UK, we are now using two-side wide local excision as well for the over 50 patients where they do not require tumor bed boost. Paget's disease, I remember it used to be a contraindication for breast conservation surgery, but once it's been imaged and no other cancer found, a central excision is safe. Um, they require MRI or contrasted as mammography to ensure that there no other lesion is missed. So central wide locum can easily be used when there are clinical concerns for the cosmesis, then use the oncoplastic breast technique. When I was looking for these for this topic, so I've come across some landmark articles for in oncoplastic breast surgery. And the landmark changes in the horizon of the breast cancer treatment. I'm happy to share with them. I'll email Theekshana and um, you can all read about these. So I end up with you with this note by a cancer survivor that breast cancer changes you and the change can be beautiful. I think when we are empowered to treat our patient with all our options, we end up a happy patient. And this is important in their journey. Breast cancer surgery does not need to be a trauma to the patient or a long-term source of worry for the patients. So I close my presentation here.
Thank you very much, Mrs. Kayani. It was an excellent talk and very comprehensive, and you touched upon almost everything that we intended to cover. A few questions have come up. Um, Starting off with dual planing, especially when you're doing level 1 oncoplasty, you have to move the breast tissue around. When would you, apply caution when you are moving breast tissue, especially in both planes? Under the skin as well as just above the pec major. Would you do that, or would you just use one plane to move?
That's a good question. So, one and deciding about these factor, it starts off with the patient selection and imaging as well. Glandular breast are they allow you to have some mobilization of the tissue in both planes. So, a fatty breast carries a more risk of fatty breast carries more risk of fat necrosis. So I would recommend minimum mobilization in level 1 techniques for fatty breast, but the glandular breast you could mobilize in both plane. What you would not want to do is to go beyond the resection margin or extensive undermining of the skin and the breast parenchyma, which can result in the traumatic injury. So it has to be balanced with the volume, what's available to you. Um, Generally, but not go too way far beyond the margins of resection. Only allow resection as much that it allows you to bring the breast pillars together.
Thank you. Thank you very much. Another question, like in our setup, there is a major issue with, people not wanting a symmetrizing operation at the time of the breast cancer operation. If there is a significant discrepancy by whatever the technique we use, patients are mostly happy with having that discrepancy, but preserving the breast. In your practice, would you consider this size discrepancy as a limiting factor to offer a technique?
And yeah, again, good question. In our routine practice, we like to symmetrize patient at the same time. with the availability of obviously expertise and surgeons available to scrub teams, it is better to have the symmetrization at the same time. It allows a bit better patient outcome. It avoids a second operation. Symmetrization, if you can do, you have got logistics available, it is the best for patient. For patients who are not willing to have symmetrization and it leaves patient with the asymmetry, then um, some scenarios, if you have expertise available, you could combine the replacement techniques with the volume replacement rather than volume displacement, which would allow you to maintain symmetry. And sometimes you can use both techniques, reduction and volume replacement, if that allows you to have maintain this symmetry. But these will be base to base, case to case to based, individually based decisions for patients.
Thank you for that. And another question that has popped up is this multifocal tumor. In our setup, having multicentric, rather in multiple quadrants, if you have tumors, it's a justifiable reason to offer mastectomy. Would you have issues with, if it's a fairly large two tumors in two separate quadrants, giving radiotherapy, and I think you touched upon this in your presentation. Would this be something that you are worried about before offering breast conservation?
So, as having more than one tumor is not an issue with the with us. So, what we in our current practice, and there should be maybe two scenarios where you have enough volume available where you can remove the whole footprint of the disease with en bloc technique, and that does not prevent you from having breast conservation surgery. I think the consideration of or the issue of the radiotherapy comes in when you have far apart tumor in two different and far apart location. For small tumors, postmenopausal or over 50 years old, our MDT allows to have two wide local excision, and our radiation oncologist, they are happy to radiate the whole breast. So where you don't expect the boost, you could easily do two wide local excision. But if you expect someone to have the boost, which are young patients, grade 3 tumors, then you need you can't have two wide local excisions. So currently we are not doing this is not standard of practice. But two distant tumors or a large footprint of tumor with multifocal disease, we do consider for breast conservation in suitable patients.
All right, thank you very much. I thought of just being somebody who's practicing in Sri Lanka in a low resource setting. I thought of popping some of the images of some of the cancers that come in challenging locations, maybe to give your opinion as well as what we've done. Some of the technical options are not there for us, so we have to just work on what's available. So I think this is something that you've explained there. So we commonly get patients with wide local sort of lumpectomies done without a proper assessment. So she had a scar just above the nipple. We had to resect that bit and also do a sentinel node biopsy. And what we offered was something that you touched upon, the oncoplasty, the bat swings. Would you now for this? I thought it worked because the breast is not very small. Would it work on somebody who has a small to moderate breast?
I think small breast, you will have to use a very small batwing mammoplasty. It looks like it's quite a sizable reduction in the upper quadrant of the breast, and she had a good volume. So, with the minimum scarring, I think it's a good technique for someone who can do this. You could consider a therapeutic mammoplasty for that, but again, it requires, you will be subjecting patient to symmetrization to the
That's
other
right.
end.
Mm.
So this is a good option. This is an excellent option in the limited setting when your patient is not willing to have symmetrization on the other side.
And this is a
Um,
very elderly patient as well, in close to
abs-
70s.
Yeah, absolutely. This size of the breast, it works. Maybe slightly smaller than that would work, but for a B or C cup size, the bat wing is not a good option. It leave for this size of excision, it would leave a lot of scarring for the small size breast.
This is another one. I think you've touched upon this. This is an upper inner quadrant tumor. We marked something else, but we've done a round block excision. Again, you've explained this quite eloquently. I think you've touched upon this triangular resections. I've done a few of those now.
Rose
The
triangle.
Boris
Yeah.
triangle, yes. Um, but in my short time in the UK, I have not seen you practice. It's probably because the incision is too big and it's cosmetically isn't the greatest. Are there any
Mm.
concerns like that? I've rarely seen, actually not seen at all, anybody doing a Boris triangle there.
Yes, one of my colleague is very good at doing this. I think it is an excellent technique for patients with a visible tumor in upper, outer, or especially those reaching up to the skin,
Hmm.
where we normally think the VCS cannot be performed. So it's a good technique. I myself have not done any with the Barrows technique, but it is nice. Again, you have got good results with that symmetry of the breast without, compromising um, appearance. Scar normally has a lot of angles, so
Yeah.
we could end up having a bit of problems at the edges, as you know.
There is some, you can
But
see some of the edges weren't healed initially, but we got away with those.
yeah,
A similar example, she had somebody with hidradenitis suppurativa in the axilla. This is one of those. This is the lateral mammoplasty that you described. Um, when the lesion is sort of large, or the breast is the proportions aren't matching, um, can you combine this with a flap, or have you done that way? As in, make the incision like the lateral mammoplasty, but then if the breast tissue isn't enough to fill up the gap, would you consider putting a flap inside, like a LICAP?
um, I would probably not combine both techniques. I would be going for only one for medium-sized breast. For this patient, if she's willing, then I would be thinking of doing a therapeutic mammoplasty. The reason being, with the lateral mammoplasty, long time, there are still some concerns about the scar deviation laterally.
Mm.
You can see in this patient, it's early she's in scar contraction phase, but it has resulted in nipple moving up and slightly deviated to the left. So if she's willing, it's obviously when we make those decisions, we make in consultation with the patient what their preferences are. But in my opinion, therapeutic mammoplasty is for the large size tumor is answer to lots of tumor size, and for this one, but must be better than the lateral mammoplasty because volume allows you to reshape, reduce, but the drawback would be that you would be committing to the symmetrization on the other side
So,
because you will give patient asymmetry.
and there's another one of those. I actually discussed with one of your colleagues, Mr. Goel, before operating on this lady. She had a right side large phylloides, came as benign. Sorry about the staplers, that's what we have. But we ended up doing an L tap and taking a bit of skin as well. at the end, the histology came as a benign one with a malignancy, small malignancy within it as well. We got away with that. LTAP and LICAP. I mean, would you just we didn't touch upon the techniques, but would you mark your perforators, or do you go by anatomical landmarks?
So, yeah, I have done both. So, in some scenarios, I have gone in without Doppler.
Hmm,
But the problem without not using Doppler to localize is that you are working in a blind field on a faith that there will be suitable perforator, which does not allow you the flexibility of creating your ellipse of the skin unless you find a suitable perforator. Only then you could decide how to mobilize this and how much would be, you will be able to reach with that available when you haven't used the Doppler. So I recommend to use Doppler before starting, so you know where your perforator is, and you have a roadmap, and you can fashion your ellipse and excision and where you would, sit in the flap.
Oh, and
Do you have Doppler available?
yeah, and would your technique be along the IMF crease, or is it going along the posteriorly, extending posteriorly?
So I mark the lateral memory fold, and then a line at the inferior memory fold going laterally,
Hmm,
and then I listen to the perforator, and then I draw up like a leaf pattern,
hmm.
excision going posteriorly,
Okay.
away from the axilla.
Early from the axilla. Yeah, this is another LICAP.
But for the your LTAP flap, you do end up close to the axilla because that's where your
Vessel is coming from.
perforator
Yes,
is.
yeah.
Yeah.
So this
The
is,
anterior axillary line.
yeah. This is an example of a therapeutic mammoplasty. Um, you mentioned about secondary pedicles. Now, in our setup, sometimes the tumor is quite big when they present, and then we end up losing a lot of tissue. Sometimes we try to preserve this, medial or lateral wing and try to keep as much as tissue. Is there a danger of sort of as you see on my picture on the left, is there a danger of leaving this kind of medial flap? Is there a chance of necrosis? Is it high, or is it robust enough to sort of withstand?
And I haven't had problems with these when I use secondary pedicles
Hmm,
because your inferior parenchyma is all intact. Its blood supply is intact. I think the risk of fat necrosis is because of the fatty breast
hmm.
and mobilization of the tissue, not in fact, devascularization. So the extent can contribute to enlarged breast, but I haven't. With the medium sized, when you do not, mobilize breast tissue too much, and the breast density is still good, they work well.
So these are some of the therapeutic mammoplasties I've done after coming here. So this is another one that she has a wire there, but we have difficulties in sort of localization as well as confirming after excision. So we did a MyCap. Um, in your opinion, when it comes to ICAPs, LICAPs, would you do a tunneling or sort of a flip over? Is there a preference?
Is this a medial quadrant or a lateral
This is
quadrant?
actually a MyCap. This is actually a MyCap.
This is a
Oh,
my gap. Yeah. So I think the problem with this, you have to damage the breast chyma, parenchyma to mobilize the breast up.
hmm,
And the defect should be enough that your mobilize is easily it passes through without any, with the swelling and edema after surgery. There
yeah.
shouldn't be any compression. So I make a big kind of mobilize it, make a big tunneling to mobilize the flap up.
Right. Thank you very much for all that input, Mrs. Kayani. I think it was a really useful discussion.
Never lost
Especially,
you.
no, you went off for a second, but you came back. Hello, can you hear me?
Hello, yeah. I think I lost you for a bit.
Yeah, yeah, we're good. Can you hear me?
Yes, definitely. Yep.
Okay. Thank you so much for the input, and it was a pleasure to talk to you again after a while. Thanks a lot. I think we have answered almost all the questions, and this will be online for people who couldn't join to go through on YouTube. Um, Once again, thank you, Mrs. Kayani, and we'll meet up again with another discussion with another expert.
Thanks for having me, Theekshana. It was a pleasure.
Same here. Okay, thank you very much.
Thank you. Bye-bye.
Bye.